We are now welcoming Christina Wahlsteds, who's a nutritional care nurse,
yes.
and Erika Baraldi, who is a psychologist. And they are both from the multidisciplinary team of eating support and gastroenterology at Karolinska University Hospital. And they will share their experiences and challenges with preterm children. Okay.
Well, do you hear me now? Yeah. It's very good to be here, so thank you for letting us come. And it's been a very good, interesting day today. My name is Christina Wahlsteds and I'm a nutritional care nurse. And I started working with these children that didn't want to eat in the beginning of the 90s, because then I worked at the neonatal care ward, and suddenly some of the children started to live. And they became 1 year. They had been born earlier. They had lung diseases, and they lived, but they didn't eat. And then we started to work together at the hospital I worked in with a psychologist and psychiatrist, dietitian, and that's the way it's been going on. And then I started here in Karolinska 2008, and then we started the same team here.
And I'm a clinical psychologist from the Child and Adolescent Psychiatric Unit, but also a part of this team. And we want to show the rest of the team, so can you please stand up?
Yeah.
This is Anneli, our dietitian, Anneli Byström, and Elinor Strandberg, who is our speech and language therapist, and our medical doctor, Cecilia Zetterström.
It was impossible for us 5 to talk, so we decided that we made the speech.
And our agenda for today is first presenting the multidisciplinary team, then presenting our patients and our inclusion criteria for having care with our team, then the process that the patient goes through in our team, and 3 main themes that we have discovered seems to be very important when it comes to feeding techniques later after discharge for the extremely premature and premature babies. And those themes are towards independent eating, nourishing food, and the importance of communication. Then we will tell you about the importance of teamwork and some future challenges for our team.
This is our the whole pediatric multidisciplinary team. I don't think Anneli is on our dietitian. She was away eating then. And we have different roles we will come to that. When you come to us, we have a detailed referral for assessment. The children that come to us sometimes come directly from the ward in the hospital, but usually they come on a referral, and this is what we want. We want them to be less than 2 years of age. We want to know their history. We want to know what they eat. We want to know how is their weight and height growth, and what previous medical problems do they have. And if we shall treat them in our team, it must be possible to treat them as an outpatient, because we don't have any rooms in our hospital. The process when they are coming is that after we have taken the referral, they come to a meeting with us, and it's the whole team, the whole multidisciplinary team. And we ask them what is the problem and what do they want help with, because maybe it's not the same thing that the doctor wanted to parents. Maybe they had a different problem. The doctor makes a medical exam. Is everything done? Shall we do something more? Shall we take some tests? How is it with a child? The speech therapist looks maybe at the development, and should we do anything else? Is this child really swallowing really good? The dietitian looks at the calorie intake and what is it eating. The nurse is me. I look about everything, and the psychologist we will talk about more.
I'm asking about traumatic events for the parents, and also look at the interplay between the parent and the child.
Yeah, and then we try to set a goal with the patients. what you want us to help you with, and then we set milestones. So maybe they say, we want our child to eat everything through the mouth because maybe they have a nasogastric tube or something. Then we take one step at a time. And the one thing that we say is that we will share the responsibility for the weight with the parents, because they are usually very anxious about the weight and it's not growing, but we will do this together. We will show it's a stepwise process of learning to eat. And then they come to us weekly, bi-weekly, every month. It's very individual, and we keep the visits about 45 minutes. The patients that come to us, we have noticed we have an increasing number of premature children that come to us. We made a count in 2008 to 2012, and to see what kind of patients did we have. Then 21% of the children that we were treated were born premature. And we didn't really look at what week they were born, only that were from the premature ward. Then we looked from 2013 and to see how many children we had, and then we also took the weeks. And then 45% of the children that were coming to us were born before week 33. So that can depend on many things. It can depend on that we don't have so much children with a heart disease that don't eat anymore, or other surgical problems. Those children we don't see so much in our eating team, because I think maybe now when you have a heart problem, you get operated almost straight away. Some years ago, you had to weigh 10 kilos and you had to do everything, and then they had to have a tube, and you had very anxious parents. They have to weigh 10 kilos, and it waited, and the children didn't feel so good. The average birth week we had for the children was week 27, and the range was from 23 to 33. And we had several of the children were very small. They were less than -5 standard deviations on the weight curve. Some were 7.5, but the weight curve doesn't go down to 7.5, but you could be there. We looked at the additional diagnosis the children had, and some of the children had many more than one diagnosis. They could be both cardiac and lung disease. The thing that we saw when we looked at the children was that when they had more than one additional diagnosed, except from being prematurely born, it was harder to teach them how to eat. We had, I think it was 2 children that didn't have any other diagnosis, and they were easy to learn how to eat.
Yeah. Okay, now we come into the 3 themes then. And the first theme is about towards independent eating. One key to later nutritional problems seem to be that we as human beings, we continue to do whatever we're taught to do. Not only the child is prematurely born, but also the parent is prematurely thrown into the parenthood that they are often not emotionally and practically prepared for. And what is said in the neonatal unit during the first very, very critical days often stays in the parental mind, even though the children might be 1.5 years or even 2 years of corrected age when they see us. So even though when they come to us, the children has to learn how to discriminate between how hunger feels and how to discriminate between hunger and fullness, and how the process from hunger to fullness looks like, because that might be the first time for them to really experience that. And ever since Ainsworth and Bowlby's days, we know that a secure base and a safe haven is crucial for a child's development and toddler's development. And maybe our multi-professional or multidisciplinary team serves, or we want it to serve, as a safe haven and a secure base for the entire family. Some place to go and discuss these issues and problems, and then go home and test something, and then come back for more advice later on. So what we want them to do after discharge is to mentalize and to go from a state where they think that the child can die at any moment because it's so ill, unfortunately, to a child that is competent, a competent baby with all his or own unique proximal zone of development.
This is a step that we use to help both the parents to see how the process is going, and we made it, it's 8 steps in children receiving enteral nutrition, because many of the children that we get have a nasogastric tube or a gastrostomy tube. And some children that come to us, you can't even touch their face, then they are down, right down there. And maybe then the parents can start just kissing and touching the face, and then the fear of touching your mouth. But then they start maybe to put things in their mouth, and they find they have a mouth, because some of the children have had a lot of operations and a lot of things stuck here. So they have to be very soft and nice to them, caring. Then they start maybe to drink water, the babies, and usually we have written weird beverage. It could be coffee, it could be beer. Things like children shouldn't drink, but they want to taste other tastes. And then they start to taste sometimes, but they don't swallow. They usually keep it in the mouth and then they spit it out like a hamster. And then they try to start to take the spoon to the mouth and swallow occasionally, and then eat occasionally and start to chew, and then there be more regularly eating with temporary dips when they have a cold or something, and then when they eat satisfactorily. And this is it helps us with the parents, because mostly the children are maybe there to touch and feel the food, or maybe they put the things in they usually are not right down there.
And very often the parents also goes through a process when they're in our team. Of course, this is very individual, but it can look a bit like this sometimes, although the individual differences are, of course, very huge. This is not an uncommon process. That coming home seems so nice when you're in a hospital. You're looking for that day of discharge quite often, with some fear, but also looking forward to it. And often it feels quite nice to be home for many families post-discharge, but then another feeling comes, a feeling of fear for the future. What will happen to my child? What will happen to me as a parent? Will my child have any additional diagnosis of medical kind or psychiatric diagnosis or something? And then it's nice to have someone who can be your safe haven, who you can go to and discuss those issues and stepwise go through to a parental self-efficacy. But this is largely affected by in what state the parents are. There are a lot of parental anxiety, depression, and or post-traumatic stress disorders in this stage, of course, if the child has been extremely prematurely born especially. It's grief still, grief over pregnancy that is lost, grief over breastfeeding that might have been lost, or grief over pumping that has been so stressful because you don't get so much milk when you pump sometimes, that's also a traumatic event for some parents that they still bear when the child is 2 years old. And sometimes also grief over a lost sibling.
Our principles, when we have at the meeting where we learn how to eat, we sit in a room and we have a table, and sometimes they bring food with them. It depends on how old the child is. So it's very individual. you liest. That's what I said. What we try to do in everything is to stimulate self-activity. The more initiative, the better. And even if they are small, like you showed on your picture, they show they have an initiative to start to eat. And we tried also then to show the parents, do you think it's hungry now? It's doing like this, and maybe putting the fingers in the mouth. And so we try to stimulate that, and also stimulate that the child can hold something. They can maybe put it in the mouth themselves. Some children maybe have a disease or something that they are floppy or anything, but you can always help to see the child's abilities, and that what we also point out when we sit together. We also work by the pleasure principle that we have been talking about today, that everything should do with pleasure. And then when we see what makes pleasure for this child, we can try different tastes. Is it salt? Is it sour? What does it like? Then we build on what works. If it likes, I don't know what it likes best, but then we build on that. If it likes strawberry, you can always take something with strawberry tastes, and then mango is something that almost every child likes.
Sometimes quite spicy things, like the Swedish gingerbread is popular.
Yes. But just something to wake up and make them interested. And also that we have sensual experiences, also, like you said, with all their senses they eat. They eat with their hands, they smell, they take their whole body full with food. We also try to establish the relationship between hunger and food, because these children maybe have had stomach aches, but they weren't hungry. They really don't know if it's hunger or if it's a stomach ache. And the thing is also that we don't provoke hunger too rapidly. You can't just come to us and we take away the nasogastric tube and say, eat, because they won't have the skill to do it.
The second theme that we saw was the theme of nourishing food and the nourishing social environment, because we want both good calories and good memories for our children.
And we think it's challenging to find best evidence-based practice to what we prioritize. No, I think that's a hard word to say. Prioritize. If it's eating, practice or growth, what is the most important? It's hard to know where should you put the ribbon. Sometimes we have children that come to us that are force-fed because the parents didn't want a nasogastric tube. Then sometimes we have to put down a nasogastric tube or a gastrostomy to reduce the stress, and then they can start teaching how to eat through the mouth. And when they get a gastrostomy, we always have them eating through the mouth, even if it's just a little.
The question is, can you reach both good calories and good memories for these children and the family? Because most of our families are caught in a stressful cycle of feeding the child signals that she or he is full, the parent would urge the child to eat some more, the child is uninterested, the parent may use distractors as iPad, making funny faces or watching the TV, and the child eats without noticing by then. But then this quite often ends up in the child throwing up, unfortunately. And then sometimes the parent would estimate how much food is thrown up, and they would re-feed the same amount of food. Not the same food, of course, but the same amount of food. And all this process takes a long, long time. So it might take an hour or more. So then it's just 1.5 hours left until the next feeding, if you have a 3 hour, which you shouldn't have, but most parents have that in Sweden today, I would say. So what we want to do is instead to work after a play and pleasure principle. In Sweden we have a saying, you shouldn't play with food, but we say the opposite. You should really play with food. So apart from growth, a healthy social interaction is one of the most important developmental steps for the child, so we try to offer them both. Another very important thing is, of course, the communication between different clinics. We have to have some sort of consensus between clinics, so the parents aren't the one who has to be the care coordinators. We're walking from clinic to clinic to clinic and being given different advices from every clinic and then trying to mix it all together to their own care at home. So this is a challenge because we don't have enough time in the hospital care here in Stockholm, and I guess it's the same all over the world. And another issue is, of course, that parents today have modern healthy lifestyles. Some parents today only eat 5 days a week, and 2 days a week they would starve themselves, for example, because that's a way of eating in Sweden today. And this doesn't match very well with how children and small babies should eat. And they would also quite often try to exclude some types of food because that is very dangerous all of a sudden. And then I'm not talking about junk food really, but other foods that might be popular to exclude. And even, it's not only the parents that seeks information at the internet, also the babies use internet as a distractor in this group, of course. But I want to say, of course, internet is not only bad. You can get a lot of positive and good advices from internet as well, as baby-led weaning, or those Facebook groups where parents meet each other and talk about the best tips.
Now I'll talk a little about teamwork, because it's a challenge to work like this. We have people that should collaborate together, but it's a very good form to work. I wouldn't work any other way. It helps us to minimize mixed messages. We know what we say to each other. And when you work as a team, you share the joy and the burdens with each other. There's always, sometimes you can get support from your colleagues, but you can also share the joy when the child starts eating. And the thing is also that when you work in the team, there's always, you only have to take care of your part, because there is someone else that can take care of their part. If I get worried, is this child sick? Or is it something else? Then I go to Cecilia and she can look and see, has it a disease, or does this one swallow really good? And then someone else can take, and I don't have to take care of all the anxiety or depressions or whatever.
No, I take care of them.
You take care of them. But it can be hard work, and it requires a long and close collaboration, and we have to speak to each other, and we have to meet. We meet a lot, and when it comes new people and staff turnover, it can threaten the team and require some more time. But it's worth it.
We do have some challenges for the future, though, that we want to share, and this is our last slide.
When is the child ready to eat through the mouth? When is the individualized assessment? We've been hearing about that today. We even heard that was it 26 he was sucking?
26 weekers.
Yeah, and that's very good. We also want consensus among clinicians involved in the process to avoid contradictory advice. Everybody knows how to feed a baby.
As well as a psychological split, I would say, because it's very common that some professional group would say, but that other professional group, they're always working in this way, but we're doing it in a better way, and the other way around. And that is also very confusing for the parents, of course.
And when is the best time for the child to introduce to us, to the feeding team? Is it when it's very small, or should we wait a bit to see before it's... We don't know really that. And what should be the ground for intervention? Should it be the age, the eating behavior, the parental stress, growth, clinicians' concerns, or what?
Or something else. Yes, thank you.
Thank you.